Okay, go.
All right, the Doctor-Patient Forum Indiana chapter welcomes you. So first of all, I'm going to go over the crisis we face as pain patients in the United States and in Indiana. So as you know, in 2016, the CDC issued quote-unquote guidelines for opioid prescribing that included restrictions such as opioid contracts, urinary drug screen requirements, and random pill counts. Indiana took it a step further and passed legislation requiring that we, as patients, cannot receive more than a 1-week supply of opioid pain medication from a provider for our first script. Subsequent scripts could be up to 30 days at a time, and legislation, which I'll discuss later, discusses a type of guideline for ER visits and how to treat patients for pain in the ER in the state of Indiana. Additionally, the DEA, presently led by Ann Milgram. If you notice that last name Milgram, I think it's quite fitting because it goes along with the Milgram experiments of the past, which included torture. You might want to look into that. And each year, the DEA has continually cut the supply of opioids that are allowed to be produced by manufacturers and how many opioids are allowed to be distributed to pharmacies. And companies such as AmerisourceBergen, there are 3 major companies that distribute opioids in the United States to pharmacies and hospitals and so forth. And companies such as that require that pharmacies dispense a certain quantity or ratio of non-narcotic, non-opioid, non-controlled substance medications compared to the number of opioid and controlled substance medications they dispense. Now, do companies like AmerisourceBergen tell these pharmacies how much of one class of medication, opioids, they dispense before they get red flagged or whatever, compared to non-controlled medications? No. So their formulation, their formulary on that is not given out to the pharmacies. And so that might be one reason why the pharmacists in some places are so anti-opioid, because they don't want to have their license or contract pulled to be able to dispense controlled substances or really any other medication. So that creates a barrier to care. Additionally, in order to have or receive opioid medication, some procedures are forced, such as, it's a type of extortion. You don't do X, you don't get Y. What's Y? What's your pain medication? And I'll go into that in more detail here on later. Another issue we have is access to care, because for most folks, in order to receive necessary opioid medications to sustain our lives, to have quality of life to some degree, we must see pain management specialists, because primary care doctors just simply rarely or do not prescribe opioids, period. Particularly younger doctors, because of the anti-opioid hysteria that's being instilled in them in medical school and training. So it's generally older providers who haven't an issue prescribing opioids because they've seen the benefit in clinical practice that it has for their patients. And so, finding a provider who will prescribe is difficult, because additionally, a lot of former pain management physicians have left the field, not necessarily due to the opioid crisis or that they were a pill mill provider, but due to the fact that the strenuous requirements for them in order to be prescribing opioids have been such that they don't have the wherewithal to keep up with that, or they're afraid of the DEA coming after them, or the state's attorney general. And it's a scary prospect. We've seen doctors 80 years old locked up in prison for 20 years. Do you think that physician is going to live to be 100? No, they're going to die in prison. scary. And additionally, we face denial of care, whether it's in the ER, where they say, oh no, you don't need any opioids, here's some Tylenol, here's some Toradol, here's an antipsychotic called Haldol, which is absolute poison. Here's some ketamine that'll put you out of it, and you might slip and fall when you get out of bed in the ER. And it's terrible, it's terrible. Or you go to a pain management physician to say, you know, you're not a candidate for opioid therapy, but we can do A, B, C, D, and E for it. Maybe here's some gabapentin for your pain. And you know, with gabapentin, gabapentin, you end up with so many side effects from that the benefits do not outweigh the risks. And so next, I'm going to go into pain management appointments and things to look out for, things to prepare for when you're at a pain management appointment. First thing you want to know, even before you set up an appointment, is do they prescribe narcotic opioid pain medications to manage your pain? Another thing you want to find out is, can I be co-prescribed a benzodiazepine for my anxiety and or for my muscle pain and or for my seizure disorder? Can I still be on my ADHD medication, such as an amphetamine or methylphenidate-based product, which would be, for example, respectively Adderall XR or Concerta? Another thing you want to know is, will I be extorted for medication? Well, that extortion would be procedures that don't help you, such as a nerve block or a nerve ablation. The nerve block would typically be an epidural steroid injection near the spine. An ablation would be like the facet nerves that come out of the spine. And for some people, those don't work. You can end up with tissue degeneration from epidural steroid injections. You can end up with, from nerve ablations, adhesive arachnoiditis. There are risks. In fact, the FDA has not approved steroids for injection near the spine. In fact, labeled on the steroid vials, it says not for use in epidural steroid injections. And you'll hear doctors say, well, you know, this medication, that medication may not be indicated for one use, but it's used off-label and acceptable. Well, does it state directly on the medication that it's not for use in spinal injections? This explicitly states that. In Europe and in other developed countries around the world, steroids are not permitted to be used in this type of way for injections near the spine, period. But it's a cash cow for many pain management physicians, and that's why they want to do it. Is it to benefit you? Generally not. Now, some folks do benefit from these procedures. You should know that, but again, there are a lot of risks with them. And again, you know, some physicians, some providers will extort you for receiving pain medication. You must have X, Y, Z procedures. And again, some of them will go so far as to say, well, they won't say directly, but if the procedures don't benefit you, you still have to get them because they might. And they say that because they want to make their money, not because they want to give you quality of life. And so they may say no procedure, no meds, and that's extortion, that's blackmail. Additionally, you can expect, as per Indiana state regulations and recommended by the CDC, a pain management contract for controlled medications, typically opioids, sometimes benzodiazepines, sometimes both are used in pain management, and these contracts are required. They can include things such as minimally once a year a urinary drug screen, randomized pill counts. If things aren't the way that the physician likes, they may taper you off of your medication under certain scenarios. And again, they can say, well, no benzodiazepines, no ADHD medications. If you are to have a surgery, et cetera, you need to notify us, and we will work with the surgeon to work out a plan for prescribing additional opioids to manage your pain or other controlled substances, etc. And like I said earlier, you don't want to go to a drill mill where all they do, for example, is we're just going to drill mills where they inject you, burn you with the ablations, etc. And they say no pain medications or very limited pain medications. Remember the so-called pill mills that we had, within the past 20 years? Well, those have gone by the wayside. I don't know of anyone going to any so-called pill mill with the restrictions that are now in place that are over the top, excessive. But there are drill mills. And what these corrupt individuals, physicians, nurse practitioners, physicians, etc., have realized is they get more bang for the buck, more money doing these procedures and implanting devices such as pain pumps, and there are a lot of issues with those, as well as spinal cord stimulators, which there are a lot of issues with those. Because in the case of the first one with the pain pump, well, if you can't find a doctor to continue filling that, you're in trouble. And additionally, what should be noted is just because you have a pain pump, it is still, as per the manufacturers expected, that you may from time to time continue to need oral opioid pain medications. And so you still may need those, and the doctor may say, oh, you don't need those after this procedure. Well, in fact, yes, you may. In the case of spinal cord stimulators, and I know of nobody who has benefited from these. I've heard about more problems than good. These cause tremendous issues such as pain below where they have been placed. They need to be reattached to certain spots because they've come out, etc. They cause burning sensations, randomized shocks that cause pain, potential paralysis, a myriad of issues. The representatives who talk to the doctor and say, hey, we're from this company, use our product for a spinal cord stimulator. These reps, they know better than to get a spinal cord stimulator. They've been on the record and off the record saying, in no way would we get these ourselves or have our family members get them. Why? Because they do not work and they cause so many problems. And people may say, well, anesthesiologists place them and their patients have a lot of issues, but a spine surgeon, which would be an orthopedic surgeon or a neurosurgeon, they place these and has huge success stories. That's a bunch of BS. We know better than that. So, yeah. Second part of this about pain management appointments. You will need medical documentation from potential hospitals where you've had surgeries and ER visits, your primary care physician, and or other previous pain management providers. And that is important. That includes the imaging you've had done in the past, diagnoses, what the doctors thought, etc., etc. It's a double-edged sword though, because some of these providers may say in their notes section, I don't think the patient really has these issues, or I think the pain's fake, or they took a urinary drug screen on such and such date and medication wasn't in there, or this was detected in the urinary drug screen. One thing you should know is that urinary drug screens are notoriously inaccurate and have a significant failure rate in terms of detecting what's supposed to be there and then coming up with a result of something that's not supposed to be there being there. Additionally, common medications that you take, such as, for example, Elavil, may show up as a type of controlled substance. Now, mass spectroscopy typically can better detect what is and isn't in the urine, as opposed to a kit where it just comes up with the different drug classes or drugs in it, but that's expensive. So do note that. You also, I think, need some personal documentation of your pain, such as why your pain levels are at different points throughout the day, what activities make it worse, what activities make it better, what medications you take for the pain that help to reduce it, and what medications have worked for you in the past to help reduce your pain. For example, you're in a pain crisis, you go to the ER, they give you an oral or intravenous opioid medication that works, great. Or they give you something like an intravenous NSAID, non-steroidal anti-inflammatory drug, like Toradol, doesn't help so much, that should be noted. Or they've done the unethical and they've given you something like droperidol or Haldol, an antipsychotic, and just snowed you essentially, to put you to sleep, make you quiet while you're writhing in pain. You need to note that and note that it did jack squat for you. Things of that sort. So yeah, and that includes, again, going on to this next point, what has worked for you. If they've given you intravenous Dilaudid and that's helped with your pain, like that. If you've been prescribed oxycodone, such as Percocet or roxicodone, and that's helped you, note that, note the dosages, note how long it lasted you, things of that are important. Additionally, you should note if, for example, in the past you've had epidural steroid injections and or radiofrequency nerve ablations, whether those have or haven't helped you, the duration that issues lasted and or resolution lasted, things of that sort. Because for some people these procedures do help, but particularly if they don't help you, that needs to be noted. And you should have expectations such as what the doctor or nurse practitioner, physician assistant is willing to prescribe. Is it going to be something as low and simple as Tramadol, which is Ultramam brand, which I will note that, and Tapentadol, the active ingredient Nucynta and Nucynta ER, do affect the serotogenic and norepinephrine systems in the brain and can induce serotonin syndrome. So you should note that if you're on any SSRI or SNRI medications, or potentially something such as a tricyclic antidepressant or a monoamine oxidase inhibitor. Furthermore, you should clearly explain, it's your prerogative, but I suggest you explain if you want to or don't want to have any types of interventional procedures such as nerve ablations, epidural steroid injections, injections into your joints of cortisone, because those can have issues. Additionally, saying whether or not you want to have a spinal cord stimulator and or a pain medication pump implanted in your spine. You need to be upfront about these things with your provider at the first appointment, because later on down the line you wouldn't say, oh, well, they won't say it out. They'll play, I'm going to extort you game and start with that. That's why you need to be upfront and clearly lay out your expectations with them and so forth. Additionally, generally a pain management provider will require that you utilize one particular pharmacy. Why is that? Well, one thing, it's to take care of liability issues they may face. Another thing, it is to protect you, because there is a thing called NARCScare, which uses a NARC score here in the state of Indiana. It was manufactured for the state of Indiana by Apris, which is now Bamboo Health, and it factors in your distance from the pharmacy to the provider prescribing, as well as different prescribers you've had for controlled medications, as well as when you've had different prescribers over the course of time. And that is part of Indiana's prescription drug monitoring database, which is known as INSPECT. And prescribers utilize that, pharmacists utilize it. Every year, your prescriber has to, at least once per year, check the INSPECT system to verify that you have been receiving medications from the providers that they know about, so that you're not quote unquote doctor shopping, or let's say You go to the ER, you have something happen, you're given an opioid script, and you fill it, and your primary, or your pain management provider doesn't know about that. That could be a breach of your opioid contract, and that could be grounds for termination of the provider-patient relationship, and then a taper off of your opioid medication that they prescribe. Additionally, when you're at the pharmacy, you need to be able to advocate for yourself. Some of these pharmacies will lie to you and say, we're out of this medication, or they'll be truthful, we're out of this opioid medication. Or they'll say, well, we can't tell you that, we don't know you, blah, blah, blah. Or they'll say, well, we have to order it, and we don't know when it'll be here. Well, that's generally a lie. Generally, they know when they'll receive it. Generally, they can check their stock. And generally, they can check the stock of nearby pharmacies or call them on your behalf to find out if they have your prescription medication in stock. There are ways to deal with the pharmacies. The issue is, if you need to go to another pharmacy for your medication, your provider will need to send the prescription there, because in the state of Indiana, except for rare exceptions, all controlled medication scripts need to be sent electronically, and that is to ensure, according to the state, that there is minimization of fraud and diversion of controlled meds, because someone can't, like with a paper script, that could be forged somehow potentially, that could be taken to several different pharmacies, blah, blah, blah. Whereas with an electronic prescription, it is sent to one pharmacy location by that provider, and then what is sent back to them to some device that they have, such as their phone, is a verification code that they must verify that they sent that script, and that must be sent back to the pharmacy within a specific time period. And again, there are upsides and downsides to that system. If your pharmacy's computer system is down, you're in trouble. Emergency room visits. We've all had to deal with the emergency room at some point or another. And most of us have been gaslit or denied proper pain management care, like I've mentioned before. And many of us have PTSD, post-traumatic stress disorder, from these encounters. So, the first thing I'd like to go over is narcotic expectations. Now, under EMTALA, which is a federal law, any facility receiving Medicaid and or Medicare funds, government funding, for healthcare purposes, must accept a patient into their ER to be seen. Unfortunately, in the state of Indiana and in other states, you are not entitled to a narcotic or opioid medication. The Doctor-Patient Forum is working on changing that, making it an actionable offense for a provider to not appropriately treat a patient who is in excruciating pain, or anything greater than a 3 out of 10, with some form of opioid, narcotic, pain medication, unless otherwise contraindicated. I know Claudia, the founder of the Doctor-Patient Forum, is working on that in Rhode Island, and hopefully here in the state of Indiana, we can get things working on that. But the Indiana legislature is a creature in and of itself that is difficult to affect changing, so we'll see how that goes. But one thing we can do in the ER with regard to the need of narcotics for the treatment of your pain is, let them know you're in pain, let them know what you are prescribed at home, if you're prescribed anything for pain at home. That way, if they give you narcotics, they know the appropriate level of narcotics to give you. Because someone at home taking 80 milligrams of oxycodone a day, such as roxicodone, Percocet, OxyContin, is not going to benefit generally from 0.5 milligrams of dilaudid hydromorphone. Generally, that person is going to need for initial dose, probably between 1 to 2 milligrams of intravenous hydromorphone biologic. And it varies for morphine and fentanyl, etc. And something we like to note is pharmaceutical grade fentanyl is different than illicit fentanyl. When you are administered pharmaceutical grade fentanyl in a healthcare facility that is prescribed by an appropriate provider, physician, nurse practitioner, or physician assistant, and administered by a registered nurse, and has been verified by the pharmacist, that is safe for you to get. So you don't have to worry about, oh, it's going to kill me. Illicit fentanyl off of the street, people generally don't know the dosage of that. Generally, it's very strong and unpredictable, the dosage, and it's not monitored, and it has impurities, etc. So you're getting safe medication at a healthcare facility if it is fentanyl, or generally anything else. Another thing I'd like to point out is Indiana, they have a guideline for if the types of narcotics and if a patient is to receive narcotics in the emergency room. In order to receive IV narcotics, one stipulation or recommendation is that to get them for your pain. And again, IV narcotics are to get your pain under control quickly. It is not for you to get high. You are there for pain reduction, not a buzz. And I will note that if you say you're nauseated, you're more likely to get intravenous opioid medication for pain. Additionally, they will likely give you one of or a combination of medications up with nausea, which would include Zofran, which is ondansetron, Phenergan, which is promethazine, and or Benadryl, which is diphenhydramine. Now, these people might try to say, oh, we have something that works really well for nausea. It's called droperidol. Refuse it outright. Droperidol is an antipsychotic that is meant to snow you. What does snow mean? It means to knock you out / make you so out of it that you can't really advocate for yourself to receive the medications you need. Or they will say, well, you're too sedated with this droperidol. We unfortunately can't give you narcotics now, because then it would make your heart rate and blood pressure go too low. That's a tactic that they may use. So outright refuse it. You may even say on your allergy list that you are allergic to antipsychotics. Now, if you're taking something such as Seroquel or any other type of antipsychotic, you may have issues there. But you can just say specifically, I'm specifically allergic to droperidol and Haldol. And then you should be fine. Additionally, if you do have trouble with NSAIDs, which are non-steroidal anti-inflammatory drugs such as ibuprofen, naproxen sodium, aspirin, brand names corresponding to those respectively are Advil, Aleve, and, aspirin is aspirin. Its generic name is acetylsalicylic acid. At any rate, if you have issues with those, then generally they won't try to give them to you. You can say I've had issues with ulcers, gastrointestinal bleeding. Me personally, I was taking Advil, ibuprofen, as recommended on the bottle for pain for my pancreatitis. What happened? It induced an episode of hemorrhagic pancreatitis, which almost killed me due to severe internal bleeding. So for me, NSAIDs are contraindicated. I cannot take them. What does that include? Well, that includes Toradol. Ketorolac is another name for it, its generic name. That is often something they will try to give you for pain intravenously because it can help with pain. And it can. I'm not saying it doesn't. I'm just letting you know that if you're allergic to NSAIDs, generally they won't give that to you. Now, one thing the provider might try to say is, well, Toradol is safe and okay because it bypasses the GI system, the gastrointestinal tract, and is more systemic acting. You know what you tell them? You say, yeah, I tried that before and I ended up with gastrointestinal issues and some bleeding. Don't buy their BS. Don't buy it. Additionally, in Indiana, in the guidelines for opioid narcotic administration in the ER stipulates that to receive something intravenously, the pain needs to be greater than a 6. So greater than or equal to a 6 out of 10. Of course, in all these cases, I recommend honesty, but I recommend being judicious about it. Do what you need to do to benefit yourself. And in pain that is greater than or equal to a 6 out of 10, it is then recommended that intravenous opioid medication be given to alleviate your pain. Now I'm going to go into different aspects of what you can do to ensure that your pain is appropriately managed when you're hospitalized or a loved one. One thing you want to do when they are admitting you, when the admitting physician is in the room with you, putting in orders for medications, etc., is make sure that appropriate levels of pain medication are ordered. And that includes the dosage and the frequency of dosages and the amount of dosages of medication you can have every 24 hours. That is key to ensure that your pain is properly managed. At the bare minimum, if you're on pain medication at home, you want to ensure that that medication regimen is being followed in the hospital. If you are not able to take oral pain medications, you want to ensure that the medication that you are being given in the hospital, such as intravenous pain medication, which would typically be Dilaudid, morphine, fentanyl, that it is at an equianalgesic dose to the oral dose of medication you take regularly at home. And please note that sometimes, most often, these IV pain medications wear off more quickly than the oral medications that you take. And if you take prolonged release / extended release / controlled release medication like OxyContin, Opana ER, Exalgo, Nucynta ER, etc., you will need more frequent dosing in the hospital of immediate release oral medications if they do not have your extended release medication, or IV medications because you cannot take oral medications. So please make sure all these things are taken care of. It is important. And I will note that generally when you're in the hospital, you are in a higher level of pain than you would be otherwise at home with your chronic pain. So it is important to also ensure that the amount of pain medication given is sufficient to take care of your increased level of pain that is above your baseline level that you deal with daily. So please make sure all these points are covered when you're being admitted, because it is more difficult to get these things taken care of after the admitting doctor puts in all the orders than it is to get them taken care of right then, because the admitting doctor is generally not the hospitalist or the physician that you'll be seeing on a regular daily basis in the hospital when admitted. Sometimes it may be, but usually it's not. And so if you're having issues with the admitting doctor or provider putting in the proper orders, you can deal with the hospitalist that you'll be seeing the next day or next few days, if that's not the same doctor or provider, and ensure these things are covered with them. And I also advise that if you are having issues getting your pain medications in the hospital, that you get the amount or equianalgesic dose that you get at home, either orally or intravenously, with the additional amount of pain medicine you need to cover the pain that you're in the hospital for, you ensure that you have someone advocating for you, and I will get to that shortly, and advocate for yourself. You need to know your plan of care while hospitalized. That includes knowing, like I just said, how your pain meds will be ordered and so forth. But also, you need to know the estimated discharge date, what medications you will be put on while in the hospital, ensure that they know what all you are allergic to, and something I advise is every single time you receive any medication, ask the name of the medication and the dosage of the medication. So frequently in hospitals there are medication errors. This includes the incorrect medication and or the incorrect formulation of a medication, such as you give an instant release as opposed to extended release, and or the incorrect dosage of a medication, and or you're given something totally out of the ballpark that you're never even on, and you don't know why you're on it. Now, it could be a new medication that they decided to give you, but you need to know what it is, the dosage, and why you're receiving it. And you have the absolute right to refuse any and all medications you do not want in your body, period. And I also recommend that knowing part of your plan of care includes the treatment modalities that may be utilized in the hospital. You may have to undergo a procedure such as a colonoscopy, you need to know about that. You may need to have some type of surgery in the hospital, you need to know about that. If you have any type of surgical procedure, and let's say you're not even a chronic pain patient, let's just say you're a patient who's not on chronic opioid therapy, you need to know the plan of care upon discharge for managing your pain. If you've come there with a broken femur, for example, or you've had a surgical procedure such as an appendectomy or removal of your appendix, what opioid pain medications will be prescribed to you to manage your pain postoperatively / post-injury when discharged from the hospital. And again, as I said before, you will want to confer if you're in pain management or with any doctor prescribing you opioids regularly with whom you have an opioid contract, that you communicate with your pain management provider and that they are okay with this physician or nurse practitioner or physician assistant who is discharging you, prescribing you some additional pain medication. If they are not, you need to make sure that your pain management provider is able to prescribe those medications for you and send it as soon as possible to your pharmacy. And you need to know whom to contact if you have issues in the hospital. This includes the fact that they may be refusing to give you your opioid pain medications that you are prescribed at home and that you take regularly, and or an analgesic dose of that medication intravenously. And also, if they refuse to give you additional pain medicine on top of what you already take at home because you're in a state of increased pain at the hospital. Who would these people be that you need to contact? Well, they will say contact the hospital's patient advocate. Something you need to know about the hospital's patient advocate is they are there to protect the hospital. They are not there to protect you. You know, of course, yes, I do recommend contacting them. However, I recommend you have an advocate of your own. This would include potentially a friend, a family member, someone from the doctor-patient forum in your state. I know Claudia and Bev are very busy, but someone from your state Facebook page for the doctor-patient forum, the Indiana Doctor-Patient Forum, we can help you advocate. And so always feel free to reach out because you deserve ethical health care and you always deserve a reduction in the pain you're experiencing. Another thing you want to know is, for example, if you are being transferred to a rehabilitation facility or another hospital, etc., you need to know that your plan of care at that facility will include the continued appropriate management of your pain, both chronic and acute. And so I highly recommend before a facility transfer that you have that all in writing and that new facility understands what they need to do to keep you comfortable. And now going into when you have planned surgeries. When you plan surgeries, it's a little different when you have an emergency surgery. When you have a planned surgery, you should coordinate with your pain management provider. This includes ensuring that either your pain management provider or the surgeon doing your operation will be providing you with appropriate post-operative opioid pain medication to manage your acute pain. Now, of course, this will be on top of your current opioid therapy if you're a chronic pain patient and you're prescribed opioids. You will need additional opioids to manage the acute pain. So either your pain management provider will provide and prescribe that additional pain medication, or they will ensure that the surgeon provides that pain medication. You want that sent to your pharmacy before your surgery. Why? Because sometimes surgeons lie. They're human too. Well, they're human too. So, that way you have the appropriate medication and quantity that you will need post-operatively sent to your pharmacy. Again, in the state of Indiana, the first time you receive an opioid script from a new provider, it is limited to a 7-day supply. I don't believe surgeons are exempt for that, like a pain management physician is. Therefore, if you need more opioid pain medication from the surgeon, they can subsequently write more than a week's worth of medication, which would include a month's worth of medication, 30 days. And yeah, 30 days. And so potentially your surgeon or your pain management provider may say, okay, we'll have the surgeon send in the first script and then I'll handle the rest, or something like that. You need it worked out. And so that would be your post-operative pain management plan. Again, like I mentioned, you want your medication sent to your pharmacy beforehand, before the surgery. If your surgeon and or your pain management provider says, oh, we'll send it after the surgery, you want that in writing then. You get everything you can in writing. That's good advice for not just this situation, but for life. And remember, this is an elective planned surgery. If they say, oh, opioid pain medication, well, you know what? Tell them no operation, because they don't get any money from your insurance provider, that they will not effectively, appropriately manage your post-operative pain. And then on the follow-up with the surgeon, you need to make sure that if necessary, and again, do this before surgery, they will continue to prescribe opioid pain medication that you need and will work on a tapering plan off of the medication once you are comfortable and don't feel that you need as much of it anymore. And now we go to our famous
the
detractors.
beasts.
Yes, the beasts. Name that rat, as I like it. The physicians for responsible opioid prescribing detractors. First up, we have the little devil, Andrew Kolodny, government paid rat who testifies for...
Fucker.
Yes, who testifies, he is a fucker, a little fucker, who testifies on behalf of the prosecution of physicians, nurse practitioners, physician assistants, pharmaceutical companies, and medication distributors. Why does he do this? Well, he gets paid a hell of a lot of money. This little man is a psychiatrist, it's a henchman, who works out of Brandeis University in Massachusetts. And, he thinks nobody should be on opioids. And not that long ago he was saying, well, I suppose terminal cancer patients, maybe, blah, blah, blah. But anyone else, maybe they should go on Suboxone. Well, here's the thing. Andrew, there are people out there in pain that is worse than cancer pain. My mother, she has terminal cancer pain in her spine. You know what she said was worse than that pain in the past? When she had episodes of acute pancreatitis. Next up on our list of government paid rats is Anna Lemke, part of Proud. This individual, I'm not going to say lady, this individual is out of the great Stanford University. Well, I'll tell you what, Stanford University gets an F from me because they have this creature working there. Anna Lembke thinks people shouldn't be on opioids either. She thinks that doctors shouldn't be prescribing them. I want to tell you something. The new 8-hour requirement of courses for physicians, nurse practitioners, and physician assistants, and physicians. Guess who's involved with that course? That is required for them to keep and maintain a DEA license to prescribe controlled substances. This creature, Anna Lembke, she was involved with the New England something on developing their course for opioid prescribing. And Anna Lembke is against opioids. She's, I think she's a head shrinker also, and she says it's a psychiatric problem if someone needs opioids chronically to manage their pain. And then lastly, we have the lovely, let's say that sarcastically, beast, Jane Valentine with PROP. And good old Jane is quite the creature too. She's just a flat out anti-opioid zealot who hates pain patients. They all hate pain patients. And guess what they all have in common? As government paid rats, they get paid Monday from the government, from your taxpayer dollars, to shut down responsible providers prescribing opioids to give their patients quality of life. They get paid to say companies like AmerisourceBergen, an opioid distributor, in addition to other pharmaceuticals, is a menace to society because they provide opioids to pharmacies that are then dispensed to people in real pain. And these folks, they also have one thing in common. They got big money from Indivior, the creator of Suboxone.
Yep.
And I'll tell you a little bit something about Indivior. They knew that Suboxone causes dental decay. Many people now are experiencing dental decay due to Suboxone, buprenorphine, because the buprenorphine itself, it doesn't seem to be what's in each of these buprenorphine sublingual products that allow the buprenorphine to penetrate the mucous membranes and go to the bloodstream. It seems that the buprenorphine itself, because we have seen this with Butrans, which delivers through the skin, through the dermis, a continuous delivery of buprenorphine. And it is such that the buprenorphine itself is causing bone density loss, tooth decay, and if you go to the drpatientforum.com, you can see where Claudia, the whole of the Dr. Patient Forum, has been working on a lawsuit against the manufacturers of Suboxone. And it's not clear yet whether Sublocade, which is a sustained release version of buprenorphine, again, it's injected under the skin, lasts for about, I think, 30 days. It's not clear whether that causes dental decay yet, but I'm sure if we look into it, we will see that. So we're up against a lot, folks. We're up against the beasts at Proct, it's government paid rats, the beasts at Shatterproof, which include Gary Mendel, and several other organizations. What do they have? They have money, they have lobbyists. What are we working on? We're hopefully getting some money and some lobbyists. If you would like to contribute to our cause, please go to the drpatientforum.com. We are a 501c3 registered organization, not for profit, and we're working to help everyone, particularly the chronic and acute pain patients, but also those with substance use disorder getting access to their medications, folks with ADHD getting access to their stimulant medications, and folks with anxiety getting access to their medications that they need to live an anxiety-free or reduced life. Thank you so much. Now we will have our discussion.
I had to cut mine short because my
What did you
dad
think?
just
Did you
got
think it
released
was-
from the hospital.
Oh,
Did you think it was good?
Yes.
Did a good job?